Good morning and welcome. Of course, the good evening there. Welcome from Mount Sinai Hospital. And I know this was a special session which we saw with Matthew being getting the Lifetime Achievement Award. Is fantastic. I know we are a little late, but we'll figure it out how to finish it. Our goal will be to finish by our 10:30 and your time being 8 o'clock. So Ramesh and Sripal and of course, Anil Kumar,
Prakash.
special thanks to give us the chance. I know the live relays within India has been little limited. Hopefully, they will start. What do you think? Is the expectation they will release the ban?
We are still waiting the verdicts from above. We have not heard anything definite so far.
Ah,
It's still
okay.
suspended.
With that note, while they're getting into it, just want to welcome all of you and giving the chance and starting with my associate, Amit Huda. Kini is not here because she's on vacation. We are two fellows, Tushar and Maria. And then rest of the staff, I'm sure you can see the familiar, Will, Ashley, nurses, Asif and Hakim, technician, and imaging is Kiski. Now, with that note, if they can get us ready, we can start to present exactly the same chip symposium, chimp case, which is what Anil wanted us to do. Case with a low ejection fraction, calcific left main, and this is what case we have selected for you today. So see that I have made copy of your the announcement, exactly the same, which will be the goal today. And this is the case number one. Let's get to the case directly. He's an 82-year-old male, has CAD in the past, had a PCI of the RCA 6-7 years ago, is small MI, EF about 40%, and came with another small MI at outside hospital in May 3rd. So we are talking about almost 2 months earlier, actually 3 months, almost 3 months. That time he had a 3 vessel and left main CAD. Angiogram was done, and because of the complexity, they said go for cabbage. Patient had been shopping around and then finally came to us. The risk factors are there. You see on the left, good medical therapy, and we had the old cath, and now we actually did the cath today, which showed calcific 80% distal left main bifurcation, tighter lesion in the circumflex, also lesion in the LAD, and moderate disease of the RCA with syntax score 34. And we know the EF was 40%. So Amit did the angiogram. So let's go through these cases. Basically, this is the case here. The right coronary had a stent many years ago, which is fine. There's a little bit of PDA disease. They call 60%, but I will call it less than that. Then this is the left. As you can see here, a large left main, about 5 millimeter and so, but very angulated and tight lesion in the circumflex, very calcific, 70-80%. And then there is an osteal disease of the LAD, which doesn't come out in this view, but there is additional disease in the mid LAD. You see that? Of course, little diagonal disease. So question basically was that how bad is the LAD disease? With that note, we are done already the IVUS. The question was, do IVUS versus OCT? I know India favor quite a bit of OCT. We do it also in America. The data are 75% IVUS and 25% OCT in NCDR, and about 30% PCI are being done, 32 actually, with the imaging guided in United States. So this case, because of the large vessel, we felt that it will be a better case, at least baseline, to do the IVUS. If we can show the IVUS of the LAD and Circ IVUS, I'll do live. So, okay, this is, show the IVUS, please.
Yep.
Yeah, good. Okay, this is the LAD.
Okay, start.
Right from the distal, very calcific napkin ring, calcium in the mid LAD, you can see there.
This is the media
See
lady.
that? Mid. And then it's a speed is a new IVUS, which is can go to 8 speed. Disease at the osteal LAD, and of course the left main about 5.6 millimeter square. So this is from the IVUS point of view. So let's go back to the angiogram. Let me just complete the presentation and we'll come to the circumflex to do, and of course take the opinion from our extreme the faculty. Go to the slide presentation again now. So this is where, so as I said, that this patient has syntax over 34 and he didn't want a cabbage. And we know that if you put into the OC criteria, we don't have the update on the OC of last one, still a 2017. Left main and 2-3 vessel will be maybe appropriate, M. because of the high risk diabetic. So, but clearly, once you have a heart team discussion, this should become A. And this is what we say, that you have to go through the regular process, and this is what the guidelines are, which is our last year basically, that any of these cases, complex case, you need a heart team, STS and syntax score, and then you go to some points which are not part of those scores, like cirrhosis, frailty, malnutrition. None of these patients, this patient has any of those three, so we put it together. In this particular case, he has some COPD, and so with the age, his STS is 4.2, syntax score is 34. Then question is what to do. This patient has a left main and kind of two vessel. So this is again, I use our stable ischemic heart disease, which we now call it chronic coronary syndrome. It will be on the left side because of the left main. If the clearly patient has a significant left main, and then the question comes is that patient has high complexity. And if patient has no high risk STS, then actually they put it together. They have not taken out the PCI altogether. It still remains 2A or 2B. But of course, the cabbage is class 1 indication. But if you have more complex medical issues like comorbid condition, STS is more than 4 or 5, they say, based on that, you can decide is the patient suitable for candidate or not. Yes, then goes for cabbage. If no, those cases can be tried on good medical therapy and PCI, like this particular case. Patient has good medical therapy, and this is where one point that appropriateness is. Now, as you saw on the right side, there was a lot of controversy because the 3 vessel disease and normal EF, they no longer made cabbage as the class 1 indication, but the left main point. Now, once you have the LV dysfunction, what to do? And this is the classical CHIP score, and this is the algorithm we have published quite a bit. And basically is the middle one. We need to worry about the middle, EF 20 to 40, or some people say 30. And with the complex case, that you are it. This patient is not going for surgery. There is no surgical opinion, no surgical bailout on this particular case. And of course, low ejection fraction, you can use everyone with the image, with the LV support. So this case will fall into the category of your Impala because of the various regions. Now, clearly, I know the issue from India, the cost-wise. If I'm doing this case in my hospital in ESCC, probably may just use a balloon pump. They may not use the Impala just because the cost is so prohibitive, almost 17 lakh rupees. The cost is similar to what is here. It's a $25,000. So it's the same thing. It comes out to be like 17, 18 lakh rupees, which is there. And so the second point is there is a one major trial ongoing. Remember Protect 2 was stopped in between, early failure, but showed some benefit. But now the Protect 4 trial, which is the event driven, and they have at least every patient will have 3-year follow-up. We started about 2 years ago. Patient with a severe CA multivessel disease, EF of less than 40. Now they just made less than 30 because they want to capture more patients, although now enrollment has really slowed down with that. But extensive 3-vessel disease with low EF of less than 40, randomizing them to Impala CP, rare case of 2.5. 2.5 is not available in America now. I'm sure they'll stop manufacturing, and the control will be balloon pump or no MCS. And then, of course, the composite primary endpoint is the rate of all-cause death, stroke, and durable LVAD transplant and repeat hospitalization at 3-year follow-up. So trial is on its way. It's a 2/3 done, about 900 patients. 3/4 completion. We remain actually tied now. I was told yesterday we used to be leader, but we just tied with German site with a 65 patients enrollment in the Protect 4 trial. So this is basically now for the, if you use Impala, those I'm sure with the new device now, Impala device is coming with a special low profile companion sheath. And this is what we have used in this particular case, as you can see. I'll show you it in a few minutes, and let me just complete the presentation. So this is the case, what we plan to do, and this is have a lot of discussion while we'll try to do what our next step will be, that the imaging guided complex PCI of the left main bifurcation, if required, may use IVL, and we want to show orbital atherectomy. No, we have shown the rotational atherectomy quite a bit. Today we want to show the orbital atherectomy. I know I did the first case about 2 years ago in India. Is used. We do about 20% orbital and 75% rotational atherectomy at Sinai and 5% laser. So this will be we're going to show the orbital atherectomy, and of course with the Impella LV support. Now show the camera to the this access site now. So this is the basically we always encourage just use through it with a 14 French will take 7 French, and this companion sheath is a little better compared to the old one. Maybe I can ask Amit, what is the difference in the new companion versus we were using 7 French sheaths before? Why? Yeah, so I mean it's a little easier, and so basically that's where we are now. Ready, Impella has been done. This we have done the LED the IVUS, we have shown it, and I think we should do the IVUS of the Circumflex. Are we ready with that? Any questions so far?
Yeah, thank you, Samin. I think Dr. Sharma has shown a very complex case here, but this patient is now post ACS back in May.
Yeah.
I think the question is, do you think that there's any value for physiological assessment of these lesions?
Well, I mean, the question is, if you do anatomic, you're right. If there is a question somewhere, but if you take the way angiographic part is, so let's do this. If there is any question, yes, but your left main, remember the left main, distal left main. Even in the Excel trial, we went more for the lumen, if less than 6 millimeter square. So left main is 5.4. Yep. And we'll go back to that IVUS again, and we are doing it now. So clearly, if there is a question, I would say yes, but I think this is a clear-cut case. So much so that the case was supposed to go for bypass surgery, and we had done one part. That's the anatomic, not necessarily the physiologic. But if there is a question, we can do the physiological. But let's do the IVUS now. We are in the circumflex. Right. Let's start. Show the IVUS, please.
Yeah, while you get that, I'll just make a comment that serial lesions are always difficult, right? What do you think, Sripal? Serial lesions.
Paying attention or no?
Can I start?
Yeah.
Okay, start full back. It's coming. Proximal circ. It's coming. 360 calcium.
What happened?
No, he had, I think, issue with the initially he has a trouble.
Sorry, it's not moving. Sorry, it's not moving. So 1 second, please. I live again. I do live.
But you can hear it now or no?
Okay, I start full back.
No, it's gone now. Hearing also gone. Sorry, do this.
What happened?
Okay, we are repeating again.
Sure. Okay, start full back. Coming. The prox circ. Tight lesion. And the left main. And I stop it.
You do the circ? Is there a lesion in the circ here? Because circ, it looks like the tightest, even, IVUS catheter, you saw it, was difficult in advancing at this level.
So this is the left main.
Steady now.
This is the big vessel. Yeah. This is osteocirc, like eccentric calcified lesion.
No, go and tell them, get a good microphone.
Still doesn't hear. I told him many times.
Yeah, that looks more like calcified nodule.
Yeah, eccentric, like a protruding eccentric calcium.
Yeah. The calcific protruding nodule, the lumen is less, and so we are ready now with the appropriate. So I think knowing that the tighter lesion in the circumflex will go with that, and knowing that we are showing the orbital atherectomy today, and the calcific nodule, a lot of people believe that orbital may be slightly better than rotational atherectomy, and so. For us, we have published even IVL. We call it a shaking or shaving. That the IVL is shake your nodule, and orbital or rotational, we published in JACC interventions. All are good. Some people do believe that orbital may be a little better for the IVL for calcific nodule compared to rotational atherectomy. Maybe we can take the opinion from the people that what it is now. This is the orbit. As you know, the orbit has two OAS, has two speeds, 80 and 120,000 RPM, and so this is, I put the orbital. Now comes with the two Viper wires, Viper wire advance and Viper wire flex. Flex basically is little hydrophilic in the middle, because one of the region has been 0.012 Viper wire, can give rise to more wire bias. So angulated lesion, we try to go with the flex. So this is what we use, the Viper wire flex. And most of the other cases, only thing is it doesn't give you that much support. So some cases, just like a rota extra support versus rota floppy. So this particular case will, and then the two speeds. So we use the Viper wire, the flex in this case, not the regular Viper wire or advanced we call it, and then speed. It's a two speeds, 80,000 and 120,000 RPMs. So we maybe use 1%. 120, we use 80,000 RPM only, because very early we learned that 120,000 is a problem, although people can use safely, but our teaching always has been no need for 120, because it's a very, effective debulking or modifying device, and will really shave the calcium. So that's where we are now. And maybe we can ask our panelists that experience
Yes.
about the 120
Sure.
on the orbital, yeah.
Dr. Ashikaga is from Japan. They have even 40,000, which is not being used anymore, right?
Yeah,
So please
micro. We
comment
did the
about-
trial, the coast trial with the micro, which is 40. And I think that even this current device, you make a 40 probably will be better. You don't need that aggressive. On the micro OAS, but we use a 40 and 80. That was 40, 80. Then I think it should be now. I was telling now the Abbott has taken over the CSI. That probably they should have a 40 and 80 speeds. Nothing more than that. I don't think you need more, because lower the speed, you have the complication. So maybe we can ask Sripal also what is their experience at NYU of using the orbitals and speeds.
Okay, Dr. Sharma, can I have one question
Yes.
about the orbital? And osteal is a very good position of the guide wire. It's opposite to the LAD. It's you can average more and more of the calcium. However, in the proximal side, the wire position is a very healthy area. So you can see the IBERS. So at that time, the position is very serious for the orbital. And not to touch.
So basically, your point is that wire will happen into the inside side of the circumflex at the ostium, and it will do a nice cutting of the basically for the plaque, particularly the nodule, but may not be that effect, may cause little dissection further down. I think we'll be a little careful, and I think the same. You can always change the now with the many times you can even change the wire position we used to do for the rotational atherectomy. Same we'll try to do if necessary in this particular case. Yes, the angulated lesion, you always worried about, no matter what atherectomy device you use, that of the dissections and so. So you see this, there are two of them. 80,000 and 120,000 RPM, and this is a button to start. We have to put it down. So now you can do, and this is same, will give you up to the 90 millimeter of the ablation. So first our goal will be, we do the left main to circumflex, if need to do imaging, and maybe combine with the IVL, and then do the LAD from proximal to up to the mid, where there is a circular calcium after the diagonal. All right, so ready to start?
120.
Yeah.
I
So,
think
I mean,
the
a great
80.
case. I completely agree. I mean, at NYU we do very similar. So we use 80 mainly, and in only in certain cases we use 120.
Yeah.
We do use 80.
So it's a 1 millimeter, you can go completely forward, no packing motion, which we do for our rotational atherectomy, and it's a 25 seconds. So, and you have to pull back, and during pulling back also it will cause the ablation. So make sure when you're doing the whole process that you have taken the 25. And keep same watching the blood pressure. And I'll not go further, just until this. Now this is a large vessel. This is the one I would say, the only case that 1% I would talk about, that's going to the 120 speed. Let's see, as long as we have not created any trouble, yeah, looks good. So far, it still remains very tight lesion at that after that OM, right? It's clear there, but very calcific, which we saw. And so let's go to 120.
It has to be done very slowly, 1 millimeter almost per second. And obviously, that's the only time that you'll get the debulking or plaque modification. So, okay. Any other comments, Sripal?
No, I think, all great strategies. And of course, I mean, I'm sure many of you would be thinking, can you do it without impella support? And I think if you're planning that, it needs full hemodynamics. I mean, do a right heart cath, LVDP, and then only you can decide whether you can do with less support or no support.
Yeah, and very important that we did, the LVDP was 24 in this particular case. Now we are doing a dyna assist. What are you doing?
Yeah, glide assist.
Glide assist, yeah, sorry.
Glide
Okay.
assist.
So glide assist now can come out much easier. The same. Yeah, so question EDP high, very important also. I know we talk about the EDP quite a bit, or we also know that patient with a normal EDP, you get a little ischemic, from 18 will become 40 or within few seconds. So as a part of, I'm the chair of the technical committee, and we could not come up with the conclusion, or sorry, agreement, that in the Protect 2 trial, that we need to do have number of the EDP for the trial to be done. That when you use a patient to enrollment. So EDP is not a criteria of enrollment. It is only the multi-vessel disease and ejection fraction. Okay, now we are ready here. We are done. Let's take a little picture.
About hemodynamic monitoring during chip procedures.
Yeah.
So whether we should have a PA line in this case. With impeller support, I think you can go ahead without.
Yeah. So the use of PA catheter is recommended in the Protect 4 study as well, that you can choose whether you want to do right heart catheter in all these patients. I think it does give information, as Dr. Sharma was saying, that you can look at the rise in wedge pressures, and but EDP can also be picked up on the impeller now with the current console. Once you actually calibrate it, it'll pick up, give you continuous EDP. So that's our other advantage. The other, I think the main thing is that I was going to ask you what you're going to follow up with Dr. Sharma, whether you're going to do an NC balloon or a IVL balloon, and if so, or a Wolverine.
Yeah, very good point. So since it was such a tight lesion, I mean the calcium and nodule, I will go with the IVL, unless anybody has little objection to it.
No, I think there's no objection at all. This is like, I think we have to combine, and our choice would be the Wolverine or IVL, or now Opian balloon has also come up, and actually we are in the US, actually Opian came much later than IVL in our center. So, but there are certain cases that where IVL I've used entire 120 pulses and it didn't work, and then Opian actually was able to open up that those lesions quite well.
Yeah, so remember in America we do, as you know, Ramesh, you know well, that lot with the reimbursement point of view, IVL has a very good reimbursement, particularly now. Yes. They're taken away for the OP outpatient for the time being, but otherwise for the Opian balloon, the cost is quite high. It's still $1,200. I told them that they come down to our cutting balloon cost, which is 800. Then we'll use it. So they come down to 1,000, not to 800 yet. So you have used Opian balloon as an investigational, in the beginning, but we don't use Opian at this time just because of the cost. IVL separate reimbursement. In India is different. Every device is a cost. Here it goes with the DRG. And so if you have only Opian, there is no additional advantage. Now, you have the rotational or atherectomy with IVL. There is a separate, the pass-through code, which you add, and that is a little diagonal. So I'm going with the direct, because this is all the same, the wire, Viper wire. I'm trying to go into the LED. Now, many times I say, these wires are that flimsy, so just go with your workhorse wire, and will take much more less time unless it's a straightforward. This is a little angulated LED here. Circ was very easy. This is the diagonal again, right? Yeah, let's get our things ready.
Yeah. One question from audience.
Yeah.
Yes,
Post orbital atherectomy, like in this case,
Hmm.
is there any imaging criteria post ablation to tell that you may not need IVL?
Yeah.
You can get away with the non-compliant balloon. Are there any features in the imaging post OA
Yeah.
which will tell us that an
or
IVL may not be
for that
necessary?
matter, or the RA, any one of them. So remember, they talk about that if you have seen the cracks, more than 2-3 cracks, and so I don't know. I mean, I'm still a little skeptical. So I think we just go with the angiogram. That have you done a real nice lumen? If not, you go with it. But yeah, some people believe that second imaging, and you see that there are the less cuts. I mean, if you can show the cuts, but you'll have some cuts all the time. Yeah.
But
So,
will you do more runs, Dr.
Yes.
Takasha?
Yeah, after the orbital atherectomy, I really check with the iris OCT how effective of the lesion. So, do you check with the iris after the OA?
okay, we'll do it now.
Sure.
We can do it. Yes, we'll do it. Let me just put our orbital wire into the LED because that's what we are going to do. And
So
clearly, I wanted to go direct. Yeah. Hmm.
Yeah. Yeah. Yes, Dr. Sharma. While you do that,
No,
many
I'm saying
people
I was trying
actually-
to do a direct. Yeah, it didn't work
Yeah,
out.
direct.
It stops
You're
at
going to
that
use
angle.
microcatheter.
Yeah. Now we are going with the microcatheter, and so yes.
See, whether to use impeller or whether you use multiple devices, all is dictated by patient's affordability here. And there, that is not the question. There, the lawyers dictate us. So if the patient went around for shopping and came to Dr. Sharma's lab, that means that patient is high profile patient, right? So you don't want anything to be gone wrong. So you want to take, it's like I tell people, it's like wearing a seat belt. 99.9% you probably don't need it, except maybe very rarely that you will need it. But that said, that is our bias. But clinical trial, which is a randomized clinical trial such as PROTECT-4, will give us more data. And
But in the Indian context, if you ablate by any strategy, oftentimes you can get away without using an IVL. IVL is much more expensive here. It is out of pocket payment.
Right.
So non-compliant balloon itself will do the trick. Most of the
And
time.
yeah, and other non-scoring balloon, which we are using quite a bit, is your both of them, angiosculpt and Circumflex. So Circumflex particularly, we are using that. You can go 22 atmosphere. It's a non-compliant, although it's like one wire of your PCI wire, another one of the device. So those, it's not but does quite a good job. Actually, we have seen many cases where the cutting balloon or Wolverine did not open it. You go with and it takes care of it. Okay, let's go back to the IVUS we are going to do of the LED. That's our goal now. Because everyone wants to see whether Orbital did anything to the plaque characteristics, whether cuts or not cuts. Yeah.
Sir, Dr. Deepak here.
Yes, Deepak.
It's theoretically, it's said that with orbital atherectomy, you tend to see polishing, you tend to see the sanding or the shaving, as well as some fractures in the calcium, which is deep inside the vessel. Now, our experience with our OA is very limited, but every time we follow it up with an OCT imaging, we never seen a fracture following an OA. How common is it, how commonly do you see fractures following an OA? Every time we do see sanding, we do see polishing, but then we never seen these fractures. Is it common? I would also want to know from Dr. Takashi also.
Yes. Let's talk to Takashi, because I can tell you, we have seen, we did a original, once they came in 2015, I did the first OA case. Then we did a 20 cases, we did a OCT, and we found actually much more cuts and the deep cuts with the orbital compared to rotational atherectomy. So we trying to see the mechanism which does more. That time there was the calcific nodule, we were talking a little less about it, but definitely it does more cuts. Whether it's the cuts many times those cuts in the non-calcific area.
Okay, it's a electronic interference. Okay, but I can start. Okay, start with coming. It's a block circ. Yeah.
All right.
The surface is ablated. Okay, I will
That's
stop
what
it.
we have done so far.
Yeah, I'll show
Yes,
it.
surface is very ablated.
Yep. Like here, the 6 to 7 o'clock is ablated by the orbital atherectomy. This is the left main.
Yeah.
What about that
It's a
nodule which you
nodule,
saw it at the
yeah.
ostium?
Okay, sure. So this is actually the nodule, like just after the OM.
Yeah.
And
Yeah, but the point is, it's 11 o'clock, some of the injury of the.
oh, you see here?
Yeah.
Yeah, that's the intimal injury.
Yes.
That's- I think better to go with IVL here rather than more runs. Right?
IVL.
It's okay. It's okay. It's nothing happened.
Make
And,
sure you
Yeah.
guys clean, get
additional
ready.
OA is very dangerous, and followed by the IBR is a good point for the.
Okay. All right. So I have a 3.5 IVL, and we saw that even after our
Yes,
initial.
I think the 3.5 IBR is.
Yeah, look
okay.
at that. It's still tight lesion. Look at that ostial, that proximal circ.
Yeah, maybe the 3O is enough because it's difficult to deliver the IBR balloon.
No, but we'll deliver now because we have done the orbital.
okay. Yeah.
So I expect.
Okay.
I mean, if not, then it's a bad thing.
Yes.
If we cannot deliver now, but we'll deliver. Yeah, good.
Yeah. You got it.
Because we have done the orbital. So I mean, one thing for sure, once you do these atherectomy devices, you deliver the device, you're subsequently without problem. So this is 3.4, it's a 3.5. It
3.5.
looks like a very small.
Dr. Takashi, your opinion on the cracks following the orbital atherectomy?
Go to 6.
Your opinion on the cracks on OCT or IVUS with the orbital, post-orbital,
Orbital causes cracks.
post-OA.
Yes.
Do you see just sanding or do you
Yeah.
see?
Many times I'm using with the OCT, and yes, cracks. Yes. But sometimes it's very developing effect is like this
Oh, yeah.
round shape, like this.
6.
Yes. Yeah, polish. Yes.
How frequently do you see the cracks?
Maybe the 20% of cases. Maybe due to the very
Sanding effect of this
standing cases.
compared to,
more.
so in rotor you see more, right?
Yeah.
I'll go a
Rotor
little bit in first.
develops deep calcium.
Go up here.
However, in the orbital, sometimes
3.5?
it's,
This looks like a baby
developing,
stuff.
Deep calcium.
Right. Will you come back into left main
Yeah,
also?
I'm going to do that, of course.
Yeah. Okay.
So this is, we are going up to 4 or 6. 6 is the maximum. They don't want you to go to more than 6. And we actually had tried it. Once you start going to the 8, and so balloon start rupturing. I have actually 3-4 cases, little tempted. Everything looking good. I said, let's go to large vessel, 3.5 or 4.0, go to 8 atmosphere. We have about like 20% rupture rate. So clearly with the IVL catheter, again, very effective. Do not go beyond 6 and then 8.
How many pulses have you delivered so far?
So right now we are delivered 50, 5 cycles, go up again. This will be the 6th one. And I think that will be okay. We keep some for the mid LED if necessary.
Has the waste disappeared or
It's still there, actually. See that?
Better,
We
better.
can
I
see that.
think.
We can
Yeah.
see that.
Yeah.
Good.
And your
I
plan
think-
was also after finishing the circumflex, you will do OA of the LAD as
LED,
well,
yeah.
right?
So that's why we have wire in the LED already, particularly the mid segment, which we need to take care, which is also very calcific. We saw that.
Yeah, and for the audience with IVL, every 40 or 50 pulses, it's better to de-air again because just with the mechanism, there'll be air in the balloon. And air in the balloon is a big predictor of rupture of the IVL balloon.
It's a good point because we have had ruptures at 110 and all.
Now give me the score flex now.
De-airing the balloon and then starting all over.
Yes. So now we are going with the 3.5. Before I go into the LED, I just want to complete modification because I'm happy, not that happy. I don't think I need to do imaging for this because angiographically, as you can see here, I'm going now with a 3.5 score flex and we'll go 24 atmosphere. Go up. Yeah, this is the 24 atmosphere. Still there is a dent there. That's okay. Leave it for a few seconds in there. Go up again. Position different. Center it. Yeah. Yeah. So, I mean, can't go more than that. It's a 20-24. And oscillate sometimes. Yeah, definitely better now. Now we could go 4-0 if need to be. But I think this is okay right now. If we do 4-0, the question will be, do you use a 4-0 IVL, 4-0 Circumflex? Definitely not the IVL. The cost, again, will be prohibitive. In the same way what the cost there is. In India, about 3.5 lakh. It's the same thing here. Okay. I think we'll settle with little less. Now, in this particular case, remember, there is our wire of the circuit little away. So you don't have to remove it. Usually you don't leave any wire in the side branch when you're doing the atherectomy, rotational or orbital. Laser is okay, IVL is okay. But in this particular case, you can see the wire of the circuit is far away, and we are going to go from the, so we can leave this, do the proximal first, and then we go to the mid. So same device using again, we have the IVL, still lot of pulses, 60 pulses left. Okay, good. Ready to go in? Okay. This is a 7 French VL 3.5 guide, which is the Mark 1 Boston Scientific. We use those guides quite a bit because they are very softer. The stiffer guide, of course, you can use it, but they always have some chance of a little more dissections. So we use quite a bit of for. Now you make sure that your crown has gone beyond your, has gone beyond your side wire, right? Good. Now a lot of people have done it that you can put up over the wire. Let's say guide liner or anything on the circumflex wire and then do the atherectomy. But we never do this. That's okay. Let's do the proximal segment here, then we go to mid. So we are doing a proximal now. It was less of a problem in the proximal. It was more of a distal, right?
Yeah, mid part.
Okay. Go to epicranial now. This is 80,000 RPM. Back and the gradual advancement. Okay. Now this is where the lesion was. Just want to remind everyone, our lesion there.
But you did not see any drop in blood pressures when
No,
you're doing
so far so good. Yep.
Yeah. So that's good. And please observe the hand movement on the screen, how slowly Dr. Sharma is doing that, 1 millimeter per second. And, it's different than the pecking motion of the rotor, as he mentioned.
We are working with a rotor device, which will have ablative surface on both sides. Yeah, compared to here, there's no ablative surface at the tip. In the micro OAS, we had a both at the tip and little proximal, but there was a gap. And that torsion created trouble. That's why the device has been taken out. Coast trial was okay. Was nothing negative in the trial, but there were some issues because you have a not continuous abrasive surface. There was at the tip and little proximal, but there was gap in between, and that created trouble. So they say they have stopped the micro OAS production completely, and this is it. Compared to rotational atherectomy, they are coming, working on it right now with the animal data that there is now ablative surface in the proximal part of that conical shape also, the proximal part.
But even then, do you think that, I had an issue one time that stuck OA.
Yeah.
So even though we have these ablative surfaces on both sides, still doesn't mean that stuck atherectomy catheter will happen in 0 cases. It can happen. So in tight lesions, obviously, always still be very careful. Slowly try to not similar to a pecking motion, but don't go beyond the lesion and get stuck completely.
Even if it cuts backwards,
120.
still can get stuck.
Yeah, if it is so tight, it may not actually get cut anymore. It will be just stuck there. No.
Okay, so
But
again,
very-
large vessel, it was a circular in that area. I'm going to go short segment of the mid LED with the 120 RPM. The 120, so 80 was there. Now we're going to do 120.
Come here.
Same.
Thank you. We can
advanced.
see the hemodynamics now. Thank you very much. Yeah.
They are showing us. Look, Sharma.
And key that the amount you going forward, make sure you have to remember that you have to come back also, because this, it will beep at 25 seconds.
Yeah, no, it's not coming. They are showing here. Show here.
Okay, let's take it out now. So tell us what you are doing so that for audience, yeah, what is now?
Yeah, like if you press this one, it
You
will
have to take it
start
off first, no?
blinking, and then it's a glide assist. Then
Okay.
you have to switch the brake, switch it on.
So he lifted the brake and pressed the glide assist button, and then once it starts blinking, he's backing it off. So essentially, I think it is really like Dynaglide, it's called glide assist here. And that's what Dr. Amit Huda is showing us over there.
Okay, good.
I think that the glide assist system to remove the crown of the OA. Sometimes if this is a two-wire system, it's maybe the injury of the
Side branch.
yeah,
wire,
side branch. So I did in this case is manually.
Manual pullback. That's a good point. Very good point, Dr.
Yeah, I mean, this is just to show, believe me, in my real life, I never use the glide assist. We are doing a lot of things today. Make sure Anil knows it. So few of the things which we do, just to update. I mean, question I would not do which is not indicated, but my practice a little different than what we never use glide assist. As I said, 120 is only 1% of cases. Here with the two vessels, 120 already have taken our, I would say, for last quota of last, I mean, next 6 months of 120. So that's a different, but just, yeah, can be done safely, you step by step. I think what I'm going to do is, I was again to show that whether it did anything to that circle. The question was earlier, I think Pradeep who asked with that question, that what does it do to the calcium? So we go to that mid LED, and I'll be interested myself also, that has it done some cuts into that total circle calcium, or it was just did a little sanding? Okay, make the IVUS on the top, please.
So, yes. Yes. So this is the new Avigo, right, Dr. Sharma?
Yes,
Avigo,
yes,
yes.
Avigo Plus. Yeah.
Yeah.
Avigo Plus.
So in India, I think it's still not come yet.
No, it came,
right?
came there now. It's available now.
It came.
Okay.
Okay.
Yeah.
Start pullback. It's coming. It's kind of distal, kind of myocardial breach. Eccentric calcium. Yeah, this is a 360 part. Come to the flux LED. 360 and eccentric and left main. And I will stop it.
Good. Okay, show us now that particular area, because that was a good discussion point, that does it do just sanding, ablation, or does some cut into the circle of that mid LED, because there was a circular plaque there.
Yep.
3.5 balloon.
Yeah. Actually, by IVUS, it's tough to say it's a
Show
good
the IVUS
fracture.
continues. Yeah. Tell us now. What do we see here?
Yeah. So
Let's get
this
the IVUS experts and our colleagues there. What do we see?
Yeah, so this is the mid part of the LED, 360 calcium. Actually, there is no like a major, like a
There's cut
clear
there.
fracture.
Isn't that there's a cut at 5 o'clock?
But there was also before. So I mean, by IVUS, it's hard to say it's a good fracture or not. So maybe you can try high pressure balloon and also
No, no,
see
no,
the.
that's not the point. No, Kiski, we know.
Okay.
The question was, does the orbital atherectomy makes the cut or it just ablate it? That's the question was, or sending it, whatever they say. Is there a cut here? We did 120 RPM.
Yep.
Now, what is at 12 o'clock position? Is there a small cut at 12?
But it was also before. So I think the surface is a little shaved. So
And
that.
what about 5 o'clock?
Yeah, so this is, I think the surface is shaved and some reverberation. This is kind of the smoother surface of the calcium. So I think that just the surface of the calcium is shaved, but no like a major clear fracture.
So I think that coming back to the question, I can tell you I'm not the IVUS or OCT, not even guru, not even a student. But to me, it does not look like any cuts. It looks like maybe just have abrasive. I think the question which was asked earlier, and I really need to know who asked the question. Who asked that question was a very important question.
Deepak Davidson.
Yeah,
asked
Deepak.
the
Yeah,
question.
yeah, exactly. So I think it basically just ablate it, cut down maybe the thickness of the calcium, but does not make the cuts. I think that's really we understood today by the imaging right there.
Yep.
Yeah. Right, and also you see there is a lot of reverberation, so it looks like it's a thin calcium.
Yeah, that's it.
So IVL will be very good in this case.
All right.
Yeah.
Dr. Takashi.
Yes, yes. And 5 o'clock and 12 o'clock, the thinner calcium, maybe the IVL is effective. But the other strategy is IVUS marking, then OA more and more, 120. So you can make more reduction of calcium. In this, maybe the 2 millimeter or 3 millimeter length. It's very easy to marking all these.
So this looks like a long NC balloon and looks like it's already expanded.
It's a 3.5, 3.530. Go up. I actually use a lot of long balloons. I'm the highest user apparently of the 30 millimeter balloon in the country. I use a lot of, because all these cases are long. I said, why 30? Make a 40 millimeter balloon. I'll use a 40 millimeter.
You didn't find deliverability an issue?
No, no, because you had done the ablation. No, I'm talking about only after doing orbital and rotation. Otherwise, they'll have a trouble to going in. Yes.
Yeah, right. So,
And I think this goes to show, I mean, if you trust your IVUS, I mean, post-IVUS run, there were a lot of reverberation, even though there was 360 calcification, and the NC clearly opened up.
Opened up, and we didn't go to crazy atmosphere. Crazy, I say, when you go more than 24, and we went only 16 or 18, right? 20 in this area, but there it opened up at 16 atmosphere. So definitely it thinned the plaque or calcium, but definitely did not make a true cuts. I can tell you,
I mean,
rotational atherectomy, we see cuts all the time. Go up again.
yeah. Yeah, rotational definitely we see more often. And I think, so if the balloon did not expand, as Dr. Takashi said, you go with the
48,
orbital atherectomy again and do
3.5,
more
48.
runs.
No, but let me ask you, after you are done slow few times, you change the wire position, you are done 4 or 5 times, what will it add? After, will it add any further? You do it even after 6 passage?
Yeah, he was saying to do more at 120 RPM, couple more runs.
Ah,
so that,
I see, okay, understood, yeah. So 120, I did only 2, yes.
2, yes. And now, Dr. Sharma, what is your stent strategy here?
Yeah, so clearly, so we are going to do is the long lesions in the LAD. So we are putting a 3.5, 48 Zion's sky point into the mid LAD, go to proximal, and then we do a mini crush of the left main to the proximal LAD and proximal circ. So that's the plan, 3 stents. Your 48 will not cover all the way, and knowing that the LED is about 4.0, so we'll put a 4.5 at that level. Will die.
So 3 stents will take for Dr. Sharma 5 minutes.
Good. But that's okay. We still have enough time, right? Or we passed the time.
Yeah, we have.
Good.
Yeah.
Okay. We have 5 minutes.
Have,
we'll be
time.
Yeah, in 5 minutes
we
we'll
have
finish
time,
it.
But your team is the one who's probably on Saturday morning.
Yeah.
They're working hard. Thanks to them,
They'll charge extra time to me. Overtime. Go up. Good. Negative. So actually 4.5 we may need a longer. Or you want to use a 4 only? Okay. 4 or 28 then. Right? Or 23. Bring 4 or 23 will be okay. Now, anytime you put a second stent, we always try to open the funnel, go up here. It was 16 atmosphere there. You can go 24, open it up. Good. So make it easier for the second one. So far, patient tolerating. So I can say, as I mentioned, that I've had to be very clear that our practice in America and practice I will be doing in India. So this was more of a demonstration case. If I do this case as I said, in India, I probably will just use a balloon pump. Here region is, there is no other option. We have perforation. All of a sudden with the left main, when we'll put a 2 stents, get into trouble. Hemodynamic at that time, there is no option for us. Good. So far so good. We go to caudal view and let's put those 2 stents.
So this is a usual question everybody asks. Would you come back all the way to the ostium of the left main?
Yeah.
So then 23 probably will not be enough.
Yep.
as
We're
you
going
were
to
saying,
go to
I
the
think.
bigger one. Yes. So question comes is, my answer is very simple. I know in Europe everybody say, but point is, if you come to the ostium and you're not come out of it, there always then will be a trouble in re-engaging and so. So I try to do, if there is no beaking at the ostial left main, then I try to avoid, we just bring it in the mid left main. But yes, this is definitely a different practice, ours versus, let's see here. Yeah,
What do
see,
you
left
do,
main is
Siddharth?
very good. So I will go 2 millimeter in the left main. That's all.
Yeah, I agree, and I think size, making sure that your part balloon size is, I mean, you have that size. For example, if you only
5-0.
have a
Yeah, we have a
508,
5-0, yes. Okay, so this is our, yeah. Okay, so Circ will go 3.515 because that our, now people will do a DK crush, all those cool out, all nothing wrong in those. We always have taught everybody the mini crush, mini crush, mini crush. We are very good at it. There's no problem in recrossing it because we have, we'll show, because we have done a lot of the plaque modification. So people who have trouble in recrossing with a mini crush is because they are not done some kind of plaque modification. Give me 28, right? Yeah, even proximally to come, you need 28 here.
28, I
Yeah.
think.
Yeah, 28. And hemodynamics being seen. Finally, towards the end, we are getting all things which we do usually in the beginning. Actually, I asked Anil, I said, what if I do a 12 midnight? He said, no. Better will be you do it in the morning. I said, we are
That's
not
how
good with the
we can
Saturday.
have- And the peak time is in the evening for us.
Yeah,
So
exactly.
why
That's
we
what
want
Anil
to-
said. Yeah. I said, once we are doing it, then we need to do the peak time. Yes. Okay. Now, basically, it's a 3.5, 15 when the Zions sky point went into the circ, and this is a 3.5, 28. Sorry, 40.
4-0.
40,
28, yes.
4028 going into, so let's put this little further down here. Wait a minute,
on the same
1
one.
second. Yeah, same wire, 1
So
second. Yeah, let's see
normally
no,
also
it cannot
your
be,
lab
because
is
remember,
open.
it cannot be that wire. It will not come that far. It is not on that
Maybe
wire.
there's a
Yeah,
loop.
it's a
Maybe
loop,
there's a
loop of the wire. Yeah. Remember, so it is not on the same wire. See this? It's not on the same wire.
Yeah.
Uh,
But there's probably a loop in the
Yeah.
lady.
Yeah, good. Now we'll be okay. Hold it. Now intake, you have this trouble. So usually you go to the circ first, but in this case, LED is little angle there. So I would put a circ back and you go to the LED first. So just strategize what you see in your results. Now, many times people will go with the 8 French guide. As you know, the 8 French guides are very difficult nowadays. Many companies don't even make it. No, this has to go. Okay, one more try.
There's a
But
loop,
what
I think,
happened
in
is,
the
yeah. So let's see, is there a loop? No. Now it's okay.
no.
Yeah,
No,
so
now
what
no.
happened
Yeah.
is, usually we have a run through wire. It's a fielder wire in the LED, and at that angle, see, it's giving us a trouble.
Okay. Maybe guideline or
No, but guideliner, how we'll do? 1 second. Let's take this out. 1 second, one by one. No, we'll do it in a different way. Give me a run through wire.
so the way I saying guideline, but obviously you have to remove the stent from the circumflex, load
Yeah,
the guideliner on both,
exactly. No, but that
and
will
get
be
the
okay.
stent into, and then remove the guideliner
Yeah.
again.
So what we'll do in this particular case, yeah.
So you're going to exchange the LED wire to run through wire,
Yeah,
Dr.
so what happened is, yeah, so was a big crisscross.
Yeah.
Training is there.
Okay, good. So let's say now, what I did, you know what, without changing, let's see it now. Let's go back to the LED stent again. So now what I've done is, I removed the circ stent. Tell them a new stent for the circ.
Yeah.
Yeah.
And if this one doesn't go properly, you can remove the circ wire as well, and then put it back in.
Yeah.
One way is balloon anchor in the sac.
Yeah.
Then
No, it will go. It will go.
deliver-
We don't need balloon anchor, believe me. This will go now.
Another way is the guide
Yeah.
extension.
Yeah. So guide
Or
extension,
the-
problem with the guide extension is that you already need to have put one, you put it there, then come back.
It'll increase the number of steps, but what you did is a simple one. Just get the stent into the LED first, and then you can wire the circumflex again.
Another way is
some
two
way-
wire in the LED, and then
Yeah.
deliver the stent.
Buddy-
and
buddy
take out
wire.
the wire to the sac,
Okay,
and then put the stent.
like buddy wire.
Yeah. Buddy wire.
Yeah.
And this is your buddy wire.
Yeah.
Buddy wire here was remove the buddy wire. That was the
Yeah.
buddy wire. So simple. Just want to tell everyone that this was basically happening, that at that angle of the LED, this was flimsy. The fielder wire gave a trouble. So we are using the same devices. We are not going to go to any different one. And now putting a same stent, same thus, we just changed it. So usually, as I said, teaching is go to the circ first. But in this particular case, teaching, basically was that we went to the LED needed because of the wire position. But anyway, let's see. We are done. I know we are going beyond the time now, and we're trying to just show and maybe just do one IVAS and make everybody happy.
Yeah. No,
I
we are
don't
okay
think we
with
should do
time.
OCT.
No OCT. I think you already opened.
I was,
We are,
yep.
we are also cost conscious, and
Good. 1 second. Okay.
right. What do you think? We need OCT?
No. Looks good. Go to the circ.
Yeah.
Yeah. 16. Okay, negative. Go up again. Okay, negative. So what we'll do, and I say that it's a like of modified. Why people say you have a better lumen of the ostial ostial branch with the DK crush, because you open the ostium. So what I do, bring back few millimeter here and go 20 atmosphere here. Open ostium little more before you crush it. Yeah, negative. And now remove both your wires and the balloon.
Balloon and the wire. Yeah.
And this will always move your LED, your main vessel stent further. So be careful which will happen. And now let's go back. Here, little die once again.
It came back.
I think good.
easily.
Yeah, very good. Go up.
Yeah. That looks good.
Yeah, but that's okay. You can't do anything now. Go up.
Was it a little shorter? Is that
No,
what
it's a
Amit
28.
is-
I think it's just there. Yeah. We'll go to other view.
yeah.
Good. You get a 4.58 quickly and then do the IVUS. Ready. Yeah. Okay.
Anil, any point?
Give us that 8 mm balloon.
I think the way you sorted out that problem was very educative, rather than changing wires and guideline and all. Came out very well.
Actually, what I observed is that you pulled back the wire completely.
Yeah, that was the
except for
key.
soft
Yeah.
part.
Yeah.
Right.
The soft spot was bent and that was making us appear that it was going into the circ, and looks like it cannot be on the same wire because otherwise your stent will not go that far. It will stop way before. Go up.
So it looked like what we call is now, instead of balloon assisted tracking, it's a stent assisted tracking into the LED.
Yeah. Go up.
Pre-check the IVUS again. The next IVUS is ready?
Okay, negative.
Okay, thank you.
Okay, so I'm not taking the picture. Want to keep this as a secret as the last one. We want to show the IVUS of the left main to the LED. Take the picture and then call the quit. Unless you guys want to any further. Yeah.
You do final kissing balloon recross and final kissing
Right. Yeah.
balloon.
This one need a kissing. Yes.
Yeah. But we can look at the IVUS first if you want.
Yeah. So we'll do the IVUS. Rest will continue. I mean, our guys are, I can tell you, technical point of view, our Indians interventionists are superb. No question. And the only problem is now they cannot do the live relay. Otherwise, they keep asking, invited for various meetings and so.
Right. Yeah. I mean, I thought somebody said that it's going to change soon, but
IVUS, ask him.
Yeah.
Yep. Okay, I check the image.
Okay.
Okay, start
The
to work.
IVUS, yeah, good.
It's a mid part of the stent. It's coming. Like around its shape. Nice area. Well expanded. I come left main. Yep. I think it's a great expansion. And I know
Going
major.
to show it, then we'll do our job, which I think kissing is, we already done the pot. The question is, do you do a repot? We usually don't do it. But let's just show the picture.
Yep.
And then, okay. All right. Just keep showing the engine. Good. Beautiful, my friend. If any question, you let us know. We'll just mop it up now with the kissing. I think this is just the usual, and I'm so thankful. And thankful to my staff. The Saturday morning, which is kind of taboo in cath lab, but they came in, volunteered, and thanks, Anil, and of course, good luck to your CHIP conference.
Thank you, Dr. Samin Sharma. This is the hat-trick, the third time you're doing for us, and it's we are very grateful for showing all your techniques. We'll keep continuing with you for the continuing CHIPs as well. Thank you to your team.
Beautiful.
And thank you from all of us here. Thank you. Thank you.
Thank you,
you.
Dr. Samin. Thank
Thank
you
you.
so much, sir.